Good morning, everyone, and welcome to this Friday's academic meeting, which is presented by the Obstetric Medicine Unit at Charlotte. Our presenter this morning is Dr. Abdullah Soni, who is a medical officer in the Department of Internal Medicine. He has a keen interest in internal medicine, and he's shown a lot of interest in obstetric medicine over the last few weeks that he's been rotating in the unit. And so he is presenting this morning on liver abnormalities in pregnancy on a case that was a little bit tricky, but it's basically when preeclampsia isn't preeclampsia. So please, as always, post any questions you may have in the chat, and the CPD register will be posted at the end of the meeting. And with that, I'm going to hand over to Abdullah. Take it away.
Good morning, everyone, and thank you, Dr. Zamparini, for that introduction. We start with our case. She's a 26-year-old female, para 1, gravid 2, at 29 weeks of her pregnancy. She's HIV positive on a TLD regimen for about 3 months now. Her initial CD4 count was 156 and had a viral load of 33,500, but showed a good response to the TLD regimen and subsequently had a CD4 count of 256 and a viral load of 32. There were no previous history of opportunistic infections. She also had a history of preeclampsia in her previous pregnancies and delivered at 34 weeks of that pregnancy. She was initially seen at the PMTCT antenatal clinic at Jarrod, where her BP was normal and had a normal UNE. However, she did have a raised ALT of 114 and AST of 173. At this time, there was no urine PCR done. One week later, at a follow-up visit, she complained of body aches and a headache for 3 days. She had no pruritus, jaundice, or abdominal pain. Her BP was still normal, but showed a continuous rise in her transaminases. Her ALT was now 196, previously 114, and her AST was 312, up from 173. Her urine PCR was now 0.085, which is 850 milligrams in 24 hours. In pregnancy, a normal urine PCR is less than 300 milligrams in 24 hours. So our current problem list are the following 3 things. She had a transaminitis, an elevated urine PCR, and a previous history of preeclampsia. Our top differential at this time was preeclampsia. However, her BP was normal and out of keeping. To understand this transaminitis, we should first look at the normal changes during pregnancy. The liver, like other organs, undergoes various physiological and anatomical changes during pregnancy. An understanding of these changes can help one to differentiate the physiological changes from the pathological ones. During pregnancy, the gross examination of the liver is relatively unchanged. However, skin findings such as spider nevi and palmarothema can be seen. These physical findings are especially prominent in the latter half of the pregnancy. This table summarizes the laboratory changes seen in pregnancy. Serum alkaline phosphatase increases markedly, up to 4 times the normal in the 3rd trimester, which results from the increased levels of placental alkaline phosphatase. Gamma GT is usually slightly reduced during normal pregnancy. Other liver biochemical tests such as serum ALT, AST, and total and free bilirubin typically remain within normal limits. Furthermore, hemodilution results in a decrease in serum albumin, which is accentuated as pregnancy progresses. Ultrasonography examination during pregnancy usually reveals a normal biliary tree. The only striking ultrasonographic findings are an increased fasting gallbladder volume and a residual volume post-contraction. So an easy approach to the cause of liver dysfunction in pregnancy can be divided into pregnancy-related diseases and pregnancy-unrelated diseases. The common pregnancy-related causes are preeclampsia, eclampsia, and HELLP syndrome, intrahepatic cholestasis of pregnancy, acute fatty liver of pregnancy, and we shouldn't forget about hyperemesis gravidarum. Looking at preeclampsia, preeclampsia is a multi-organ disease characterized by hypertension and proteinuria after 20 weeks of gestation that can involve the renal, hepatic, hematological, and central nervous systems. Internationally, it affects 5 to 10% of pregnancies, but in South Africa, hypertensive disorders of pregnancy are the second most common cause of maternal death. There are a few guidelines that can help identify preeclampsia, one being the International Society of the Study of Hypertension in Pregnancy, which defines it as gestational hypertension, so that's hypertension arising at or after 20 weeks gestation and one or more of the following: which is proteinuria greater than 300 milligrams a day, or any other maternal organ dysfunction, including an AKI, which is considered a creat greater than 90, a transaminitis of an ALT and AST more than 40, neurological complications, and hematological complications, including thrombocytopenia, DIC, and hemolysis. It also includes uteroplacental dysfunction, meaning fetal growth restriction. The American College of Obstetricians and Gynecologists have a similar definition to the ISSHP. However, it does differ slightly. Looking at the platelet count, whereas in the ISSHP, they consider it at 150, in the Americans consider it to be less than 100. And also the liver transaminase is at least twice the upper limit of normal compared to just being greater than 40. The clinical features of preeclampsia include headache, visual disturbances, abdominal pain, nausea and vomiting, confusion, and hyperreflexia. It is important to remember that our patient had a headache and body pains. Eclampsia is defined as a tonic-clonic seizure occurring in the presence of preeclampsia. HELLP syndrome is a variant of preeclampsia. 5 to 20% of patients with preeclampsia may develop HELLP syndrome, but it is important to note that 20 to 50% of patients with preeclampsia can still develop some liver dysfunction without HELLP syndrome. There are some useful classifications to help identify HELLP syndrome. The Tennessee classification can be used and is defined as an AST of more than 70, an LDH of more than 600, and a platelet count of less than 100. The Mississippi classification is less commonly used, but can help sub-classify HELLP syndrome, using the platelet count and dividing it into class 1, class 2, and class 3. Intrahepatic cholestasis of pregnancy is characterized by pruritus with raised bile acids in the absence of a skin rash. Usually it is found in the 3rd trimester, but can even occur after 8 weeks of pregnancy. It is associated with a strong family history and is more common in the Scandinavian and some South American populations. The clinical features include a pruritus involving the hands and feet typically, but can involve the trunk and the limbs. There is no rash, but the patient may have excoriations. The symptoms are much worse at night, and the diagnosis is usually made as a diagnosis of exclusion. However, a full workup for pruritus and liver dysfunction should be done, as well as looking at bile acid levels. Acute fatty liver of pregnancy is due to microvesicular fatty infiltration of hepatocytes. It is a rare disorder that is considered to be a medical and obstetric emergency, which can lead to liver failure. It can be quite severe and potentially lethal to the mother and fetus, and it usually also occurs in the 3rd trimester. The clinical features include a prodrome of non-specific flu-like symptoms followed by typical abdominal pain, nausea, and vomiting. Acute liver failure symptoms are present as well, and there is a transient diabetes insipidus. Therefore, the patient will experience polyuria and polydipsia. The transient diabetes insipidus is due to increased levels of vasopressinase. As vasopressinase is metabolized by the liver, the hepatic dysfunction found in AFLP may lead to increased degradation of vasopressin, resulting in the diabetes insipidus. The biochemical features include an elevated bilirubin and transaminases. Hyperuricemia, hypoglycemia can be quite profound, as well as an associated leukocytosis, acute kidney injury, and DIC. Hypertension and proteinuria can be present, but is usually mild. The diagnosis of AFLP is made by meeting the Swansea criteria, where the patient requires at least 6 of the following features. To summarize a few pertinent differences between the diseases as discussed before, preeclampsia is more common than the other conditions. They all occur later in pregnancy, and hypertension may be useful to differentiate them from each other. And as you can see, they all have varying mortality rates. So going back to the causes of liver dysfunction in pregnancy, we can now look at pregnancy-unrelated causes. So pregnancy-unrelated causes are the same as in patients that are not pregnant, but can either arise in pregnancy or be a pre-existing condition. Conditions arising in pregnancy include a viral hepatitis, hemolysis, biliary diseases, vascular alterations such as Budd-Chiari syndrome, and drug-induced hepatotoxicity. Pre-existing liver conditions include cirrhosis and portal hypertension, chronic viral hepatitis, non-alcoholic fatty liver diseases, and autoimmune liver diseases and Wilson's disease. So going back to our patient, our differential would be looking at preeclampsia, taking into account the previous history, the transaminitis, and the raised urine PCR. But the normal blood pressure at this point is out of keeping. We should also indulge the diagnosis of viral hepatitis, as she is HIV positive and recently initiated on treatment. AFLP is unlikely in our patient as the condition was quite stable. ICP is also unlikely as the patient had no pruritus. In view of the normal blood pressure making preeclampsia less likely, we opted to do a full workup including liver function tests, head study screen, and an abdominal sonar. So the liver function tests were as follows. Set 1 and Set 2 were the results we already had from the antenatal clinic visits. Set 3 was the first full LFT done at admission and showed the worsening transaminitis. Our INR at this point was normal. She had a positive Hep B surface antigen, Hep B surface antibody negative, Hep B core total antibody positive, and had a Hep B viral load of 6,652. Hep B E antigen was requested but not done. We therefore made the diagnosis of acute hepatitis B infection. So let's briefly talk about hepatitis B in pregnancy. So approximately 2 billion people have been infected by hepatitis B worldwide, and there are approximately 250 to 300 million chronic HBV infections. HBV accounts for about 1 million deaths each year worldwide. Most deaths are due to cirrhosis or hepatocellular carcinoma complications. The burden of this disease is higher in low-middle income countries. In sub-Saharan Africa, there are approximately 60 million people chronically infected with HBV, which makes about 1/5 of the worldwide infections. 2.6 million people are co-infected with HBV and HIV. The risk of spread of HBV is determined by the age of primary infection. 90% are perinatally, 30 to 60% are before the age of 5 years, and less than 10% are in adulthood in immunocompetent adults. This shows that mother-to-child transmission is the most common form of spread. Viral transmission can either be vertical or horizontal. Regarding vertical, it can be in utero, meaning transplacental, which is actually uncommon, except for acute HBV in the 3rd trimester infection of placental capillaries. It can be perinatal, which is during delivery. This accounts for the biggest risk exposure to the infant due to the infected blood and fluids in birth canal. Breastfeeding is very low risk unless there are cracked nipples or mastitis. The risk can be lowered by immunoprophylaxis. Horizontal transmission is through sexual contact, exposure to infected blood, blood products, or needles, and can even be close person-to-person contact such as open cuts and sores. The maternal replicative status plays an important role in how infectious the mother is. She is highly infectious if she is hepatitis B surface antigen positive, HBe antigen positive, and has a high HB viral load. This results in a risk of transmission of 85 to 90%. If the mother is HBe antigen negative with a lower HB viral load, then the risk of transmission drops to 10 to 32%. It is important to be able to interpret HBV serology in and out of pregnancy with acute infection. So with acute infection, you have an initial rise in the surface antigen, followed by a rise in the core IgM. Both of these then go down and you're left with a positive surface antibody and a positive core antibody. It is important to note that the vaccine only contains surface antigens. Therefore, a person who has received the vaccination will only be hepatitis B surface antibody positive. Screening for HBV should include doing Hep B surface antigen, Hep B surface antibody, and a Hep B core total antibody. Current routine antenatal screening in South African point-of-care services includes HIV, syphilis, rhesus, and hemoglobin testing. Despite recommendations from the World Health Organization to screen all pregnant women for HBV in settings with a seroprevalence of greater than 2%, the South African national policy does not currently recommend universal screening for HBV in the antenatal setting. Point-of-care testing for HBV is available and has previously been shown to be feasible in terms of both reliability and cost effectiveness. Furthermore, point-of-care testing screening would allow for testing in rural areas and midwife-led obstetric units, which can lead to rapid turnaround of results and initiation of treatment. Pregnant women with acute HPV infection do not appear to have a worse outcome when compared to women who are not pregnant, nor is there a higher incidence of acute HPV infection in pregnancy. Chronic HPV does not seem to have an effect on pregnancy itself and has not been associated with an increased risk of preterm labor, placenta previa, or abruptio placenta. However, there is an association being made with insulin resistance, but this has no increased risk of gestational diabetes for the mother. Liver cirrhosis, as a late complication of HPV, is infrequent in pregnancy. However, it does have a higher rate of morbidity and mortality when compared to non-cirrhotic pregnancies or women with cirrhosis who are not pregnant. Most women of childbearing age are likely to be in the immune tolerant or immune control phase and are not candidates for treatment, but the risk of mother-to-child transmission must be considered, especially in patients with high HB viral loads. According to the National Department of Health, in acute HPV, antivirals are not recommended unless the patient has acute liver failure. There is an increased risk of mother-to-child transmission if HPV is acquired in the second or third trimester, and if the HPV viral load is more than 200,000. Antivirals are also indicated in this instance. Chronic HPV indications for therapy in pregnant women are the same as a non-pregnant woman, except that we treat both HB antigen positive and negative. The drug of choice is tenofovir, and it has similar rates of birth defects. So the drug of choice is tenofovir, and it has similar rates of birth defects as in the general population. Lamivudine and emtricitabine are both safe in pregnancy as well. The National Department of Health also recommends the use of antivirals in patients with an HB viral load that is more than 200,000 to help prevent perinatal transmission. Tenofovir is the preferred agent and should be started at week 28 to 32, as this coincides with antenatal clinic visits. In HIV-negative women, treatment can be stopped 12 weeks post-delivery. All neonates must receive HPV birth dose vaccine within 24 hours of delivery, and a cesarean section is not indicated to prevent mother-to-child transmission. Getting back to our patient, her transaminitis resolved while being on treatment. She continued with the TLD and in hospital supportive care. She was discharged home and had a follow-up HPV viral load of 41. She continues her follow-up visits with our PMTCT antenatal clinic, and we all eagerly await the birth of a child. I would like to thank Dr. Zamparini for his mentorship in the last few weeks, as well as Dr. Murray for his infectious diseases pearls of knowledge while compiling this talk.
Thanks, Abdullah.